I'm Dr. Peter McGovern. I'm the medical director of University Reproductive Associates. We've been in practice here in northern New Jersey since 2003. All of our doctors individualize care for our patients. We don't have protocols that we plug everyone into. Our management decisions are made by the doctors, not nurses, not ultrasound technicians. Almost all of our ultrasounds are performed by physicians whenever possible. And that gives the opportunity for immediate feedback to the patient and also an opportunity for the patient to ask questions. I think we get a lot of patients for second opinions because they feel like their original infertility consultation seemed more like a sales pitch than an evaluation of their health problems and an assessment of what the options might be. We feel like everything should be on the table and it should be ultimately a patient choice with advice from the physician as to which way to go in terms of their infertility care. There are a lot of anatomic issues that may affect fertility. The fallopian tubes everybody thinks about, but a lot of people don't think about the uterus itself, and the uterus can be a problem for fertility if there's scar tissue inside the uterus, which may be related to prior surgical procedures, D&Cs or pregnancy terminations, or previous intrauterine surgery. We can see polyps, which are benign growths of the glandular tissue inside the uterus, the endometrium, or we can see fibroids, which are benign growths of the uterine muscle, and they're mostly a problem when they enter the uterine cavity. So the closer they are, or if they're in the cavity, they tend to be more a problem for pregnancy. All of these problems are very correctable. So once pregnancy is achieved, the journey is still in progress. It's not over because we want our patients to deliver a healthy baby. So we like to follow our patients for the first 8 to 10 weeks of pregnancy. This is unusual for a fertility practice. A lot of IVF centers, as soon as the patient has a positive pregnancy test, they're referred to their OBGYN. This actually doesn't work out very well in OBGYN practice because many OBs don't really schedule their first appointment until the patient's about 10 or 11 or 12 weeks, and that leaves the patients in limbo for the first 7 or 8 or 9 weeks of pregnancy. So we feel like it's very important to provide that continuity of care and ensure a very smooth transition of care between us and the managing OBGYN who's going to take care of the remainder of the pregnancy. I think it's very important that we offer patients a full spectrum of care. We don't steer everyone into IVF or really into any particular therapy. We like to offer them all the options that are reasonable based upon whatever the problem is that they're facing.